Welcome to the Anatomy of Therapy. I'm Dr. John Cybulski here with Bobby Riley. Today is single leg Craig Day. And we're going to do something a little bit different today. We're going to do some videos. We're going to have the links in the show notes. So if you want to go down just below, you'll see some links to these. This is all on Craig Liebenson's Instagram. We're also going to do a little screen sharing. So if you're watching the YouTube episode, you'll kind of notice it there. But we'll describe it. There's some pretty simple exercises that are going on. But single leg stuff is a very trendy thing. I see it all over the place. And Bobby and I were kind of discussing this earlier. Like, why? Why is everybody doing single leg stuff? What? Help me here, Bobby.
I don't know. We walk on one leg at a time usually.
Sure.
So maybe a little bit of gait, a little bit of. Well, I think there's a sense of a shift away from some of the power movements. I mean, I don't know what you did as a soccer player in high school, but I remember doing like the bigger, faster, stronger program, like,
Right.
a lot of bench press, a lot of just squats, deadlifts, two-legged things. And I think that held a lot of the, the admiration in the training industry for a long time. And and things go in phases, and obviously there should be a role for all of this stuff, but I do think it can go in waves, and I think people are kind of remembering at this point that there's more to it than like the big three, or even the Olympic lifts,
You're
where
talking
people
about
are
McGill's big three?
no,
Powerlifting?
just bench, deadlift, and squat.
Gotcha.
And or Olympic lifting, things like that. I think that's been kind of the hallmark of classical American, weightlifting or strength training for sports historically. And so there might be somewhat of a shift from that. I still think the majority of, especially high school gyms are going to be doing those things.
Sure.
But as far as for rehabilitation goes, I think we've always been, and by we I mean physios or PTs or chiros, have always probably had our one foot in the door a little bit more with unilateral work than strength training.
Yeah.
But even then, it's real easy for us to say deadlifts fix low back pain, or look at it kind of myopically like that.
No, but I do think that's a good kind of perspective to kind of start, because Liebenson is very big in the same way that like a Weingroff is, or the training to rehab. The rehab and the look is starting to look a little bit more like training. I know one of Liebenson's big first principles of movement thing is to find a person's floor level baseline capacity and work from there and then build up. So I feel like a lot of times you'll see some stuff on his Instagram where it doesn't look a lot like traditional PT, physical therapy, like clamshells and glute bridges. Although you see clamshells, versions of clamshells and versions of glute bridges, but he will have more people upright and seems like moving a lot of heavy weight, capacity and load, which looks an awful lot like training, like you were talking about, but not, again, the very traditional big three lifts in training. It's just a little bit broken down. But I mean, a couple of the videos we'll go through here, or scenarios, some of they're getting toasted. They're working their glutes, they're working their hips quite a bit. So it's kind of blending and bridging that gap between just kind of I'll hate to say it, and actually I don't, the boring rehab of like, rotator cuff, I's, Y's, and T's, where it looks a little bit more like training. I think that's where Liebenson is good at. He's going in between. One of the major critiques, I think, of his Instagram is, and it's true of anybody's Instagram, you have to have some context for what's going in. So we don't have a full history on these people. I'm sure Craig has taken history and there's an appropriate input given. But I think that's one of the critiques I've heard of him. And I want to try to, as we're going through these exercises, he'll give a bunch of little cues. He's been a clinician for a very long time, so he's got a lot of knowledge in his head. So he's giving a lot of cues. And so what we're going to do is kind of try to stop and break these cues down and why they might be good or bad, or what they might be trying to accomplish. But I say we just kind of jump right into this and have some fun. So single leg Craig Day. The first one is we're going to go over a single leg kind of hinge. Basically, we've got this young lady here. She is on her right leg, and she is going to be doing some hinge work here. So you'll hear Craig kind of guiding her through this. So she's basically doing a single leg deadlift, right? She's reaching her arm overhead. She's reaching her leg back. She's down on her right leg. Her right leg is mostly straight here. So let's hear Craig kind of coach her. So soft knees, this is already bridging over into training, right, Bobby? I mean, where have you heard soft knees before? Defense in basketball, you know, something like that. That's what I think. That's what comes to my mind.
I mean, yeah, I mean, nothing you do with a locked knee, especially athletically.
Right. And so he's already immediately kind of getting into that training phase. Let's go on a little bit further.
But the breaking of the knee triggers a whole bunch more stability and control demand on the hip and the foot, for that matter, because you're basically de-emphasizing the skeletal structure and emphasizing, you know, neuromuscular control.
Mm-hmm. All right. Again, reminding you to be soft. Okay, so he's now talking about how her left pelvis is up really high, basically. And so basically with her right leg down, her left hip is turning upwards, almost away from the ground, right? Opening it up. And he's trying to get her to close that pelvis down almost, kind of almost flex that left pelvis forward. Hold it there. Close it even more. More, the whole waist. More, drop it. Now you feel on the right butt more. Good. So once she closes that hip off, he's centering her right hip. So bringing that left hip down is shifting the weight over to the right to kind of lock that in. Now he's going to ask her to keep that. She's kind of down in the flex position. Her torso's at about 90 degrees. She's got that right glute engaged or centrated, he'll probably say. And then he wants her to keep that centration, that feeling in the glute as she comes back up here.
I'm wondering how much, I mean, maybe it's great, but I'm wondering how much like hip flexion and IR she has, because she's in this like hip airplane position, right?
Right.
Which I'll come back to, by the way. But in that position, it seems like when he finally gets her left hip not to hike, where it goes down like he's asking for, then she tends to lock her knee back at the same time. So, you know, where if she keeps her knee bent, she tends to hike her hip. And then when he asks her to turn that hip down and in, then the knee locks. In other words, I'm thinking it's maybe hard for her to keep IR of her hip. So that's why she has to straighten her knee as he finally gets her to go down. And going back to the hip airplane, she's really struggling to, like, she looks fit, she looks athletic, she's struggling to like understand physically. I'm sure she understands it mentally, but she's struggling to like understand how to keep that left hip down. Mm-hmm. Now that could be an anatomical restriction, but I mean, for me, I think it's a underutilized exercise, the hip airplane, especially the way I like to use it, which like in this situation, as she's struggling quite a bit, I would regress this to doing hip airplanes, but not from neutral to ER, but from far IR to as far in ER as she could get. Because every time she goes from fully open in a hip airplane with a right ER to hip, every time she lets that go back down, she's basically, you know, doing some PIR almost on herself, and she'll be able to find more IR, and then she can get into that right hip a lot better. So then maybe she can keep that knee bent and keep that left hip towards the floor a lot better after just squeezing more out of that hip. But again, this is where we don't know what her passive tests are.
Right. Let's go back to the, so you were saying, if she's not getting this, that this is time, doctors, clinicians, trainers, to regress. Like, as we're looking back at this video again, he's asked her to bring her hip up, but her hip back down, but her hip keeps going back up. And I don't think she's aware of it. And so you're saying to kind of put her in a better position to dominate this position, where she like would give her a better chance for success, basically. Right.
Yeah, I mean, if it's a anatomical thing and that hip actually is not a lot, it looks like she's going into like some varum there
Yeah.
almost to me. Like she's struggling to drop that hip down, and the more she does, the more she has to extend her knee and create more varum. But let's say it is fine. She has a wonderful hip. Well, in that case, I would still regress her to the hip airplanes, but that's just to get her hip to feel what it's like to go way past just neutral. So that left hip going way lower than the right hip, and then squeezing and coming way above the right hip, going down way below the right hip. And then she'll be able to come back to this and be able to sense that a little bit better.
Yeah, he has another one I want to show you here that I think tries to kind of accomplish that. But he kind of starts off with some monsters. So I'm going to skip ahead here. So there's this girl who's kind of doing monster walks, basically. And then she goes into, it looks like a lunge, but he calls it a kickstand, right? And so, yeah, here we go. So this girl has a, what kind of a band does she have around there, Bobby?
Hip circle.
Hip circle. She's got a big Mark Bell hip circle around her thighs. She was just doing some monster walks side to side, and just one direction. So she takes, say, 10 steps to the left with a monster walk. Now she's moved her left foot back behind her right in a kind of flex, kind of down athletic position. And let's see what Craig has.
Kind of like a fencer stance almost.
Like a fencer stance.
Middle linebacker fencer stance.
Okay. So he's lined her up. Now by kickstand, he's kind of got her in the single leg, band around the thighs. And by kickstand, he basically means lift up the back leg. Try to kind of, he's big into the reactivity of training, right? So he'll kind of do some quick stuff. But anyways, he's going to ask her to lift up her back foot, but she's in that single leg kind of lunge fencer stance.
Don't move your pelvis. Don't move the right leg. Good. Feeling that? Show me where.
So she's pointing to her right hip as she's in this kind of lunge position, lifting up that back leg. He's forcing her to center her weight over her right side there, basically. So as she lifts that up reactively, her body has to use the glute.
Switch legs.
Okay, so now she's going to monster walk back the other way.
Eyes, shoulders, hips, parallel.
Okay, so another cue. Eyes, shoulders, hips, parallel. That's a lot to do with this. She's doing well.
Great. Get into staggered stance now.
Okay, so she goes back to the staggered stance. We're doing the opposite side. One of the other cues with him is when he goes and he does all of this, and we don't really know precisely why they're doing all of this. He's doing very equal on both sides. Why would he be? Well, step one, he's just getting both of her glutes to fire off quite intensely. Like, this is a legit training session at this point. She's probably pretty close to the end of her treatment. Where is this useful? Where is like massive active glute activation useful in training, or I should say rehab? He's in his clinic.
Well, I think partially what he's, why things are bilateral, maybe it's only a one-sided issue, but it seems like a lot of his work is focused on not just local physical strengthening or repair, but just, it's more this complex systems theory or the integrative systems, where he knows that the metabolic nature of the body is also blends into the nature of how we handle stress and daily activities. So, I mean, doing a clamshell on the floor with 5-minute rest breaks in between might, on EMG studies, increase your ability to contract that glute. But like this one, I mean, I'm curious why you picked this one personally, but I mean, on this one, he could be working on, like you said, a bit of the rapid onset of contraction. Sometimes it's not about how hard, but how quickly things can fire. But I mean, this is a little bit, it's upright, it's frontal plane, it's all planes actually. if you think about it. It is, he goes from kind of a slow, methodical, how would you say, isometric contraction, where you're doing these monster walks, doing perturbations by picking up the foot, it's requiring a fast contraction. I mean, I'm curious why you picked this one though.
Yeah, this one's just this was a little bit closer towards the training. It looked a lot closer towards training, but it obviously is done in a rehab setting. Like at the very end of this video, you'll see it. She is smoked. She, like, her glutes, I'm sure her quads are worked. And so, I mean, and she doesn't look like an overly deconditioned person. However, I do know that there are plenty of patients that if we could just get a bunch of blood flowing into your glutes, into your quads, especially with a deconditioned population in 2020, when we're all kind of just sitting around, getting some good work into in a nice, healthy way is healthy. Not everybody needs a exactly precise 4 degrees of internal rotation, mixing their crural fibers of the left diaphragmatic position into perfect spot. Like, if you can just get a lot of work done, a lot of times people feel better. I mean, we listened to Dr. Askey's episode 2 episodes ago, where he was talking about people with, pseudo sciatica, and he's like, get off your couch, guy. I need you to go on another walk throughout the day. There are varying levels of people that will treat, from athletes to, aunts and uncles. And honestly, try not to overcomplicate it. I mean, this exercise looks complicated, but really what he's doing is just working her glutes and quads. And I do think that is very undervalued, especially if you have them there and you could just really work them. She's going to be sore for a day or two. That is going to be a major interruption to her, let's just say her back pain or something, right? So if you've got the kind of time that like Craig does in his office, where you can go and coach them through some of these things, it's a very high value rehab setting where he can take the time to kind of do these things. That's why I picked this.
Oh, that's good. I mean, sometimes you have to remind yourself, whether it's by just witnessing people in the gym or watching people do things in life, you have to remind yourself that not everybody has gone through, a CSCS or a chiropractic sports diploma for, being calling a sports chiropractor or whatever your training is in. And people don't know how to hip hinge. People don't know how to brace. People don't know how to shift. People don't know how to do things. They just do them the way that they do them, and that's it. And so one thing he's doing here is he is grooving a bit of, neural patterns here, this neuroplasticity ability. If you do enough of this stuff, you can move differently and you can move a little bit more optimally. But again, he's also doing what we've repetitively said on this podcast, which is raising somebody's capacity above their demand threshold. Right. So in some ways, I mean, maybe I don't know if she's a high level athlete or she just likes to play rec volleyball, but let's just say she's kind of, she has a job and then she likes to go for runs. You know what I mean? Right. This looks like something that would, keep her above the threshold. In other words, if she has the strength to do this and routinely do this, she could probably handle, the 10K run and how much glute med or stability that requires.
Yeah. And we'll go back to the video in 1 second. I think, to echo your point there, like, he going over his stuff and just following his work over the years, he's very much into training a dysfunctional pattern and in a pain-free way. He talks about training things that may be painful, but he's really looking after dysfunctional patterns. And so if he can train a dysfunctional pattern, coach them through that, make it functional, he can kind of open up a massive window there. I know that's one of his big things, is finding these non-painful dysfunctional patterns and going after those pretty hard. So in regards to like this specific one, her injury may be her knee. It could be her foot. There's one later where he does a bunch of hip stuff for a guy's ankle. But he is looking for, again, the dysfunctional pattern that is pain-free. That's one of his big kind of principles. Let's go back and see how he kind of progresses this one. Cool. All right, so now he's giving her a kettlebell. Staggered stance. Kettlebell's in her right hand. Her right leg is back. Her left leg is forward. Band around the thighs still.
Hold it, and now kickstand. Slower, so you're controlling it. Let me hear it light.
Gotcha. So basically, right, so she's doing the kickstand again. She's holding that weight forward in her right hand with her opposite left foot forward, and that back foot is lifting up. So she's having to control her weight over her front left foot and leg. She's got her shin pretty straight up. But the reason he's asking her to control is she's lifting that foot up and banging it back down because she doesn't want to shift all of her weight forward. So he's really asking her to kind of single leg single leg stance onto that front leg.
Good. Now hold it. We're going to go a little more towards the
So this is the capacity thing. This is the threshold. She said she's on fire. She's already surpassing an old threshold. If you feel like your muscles are on fire, that is new threshold level. And then he's like, cool, now we got a little bit more. Let's push this.
That's it.
Okay, so now, I think we missed this part. He is having her kind of bend her back knee down. She's doing a single leg squat. She's doing a single leg lunge, right? But she's hinging a bit more. She's still hinging. She's making less a squat, but more of a hinge. So her torso is way forward. The weight in her right hand is pretty equal with her front foot. And he's basically having her just lunge, deadlift forward. Really should have her glutes on just absolute fire right now.
Good.
Oh,
Now,
she's complaining.
stand tall and walk into staggered stance, leaning forward like a deadlift.
There you go.
Lean forward. Good. And kickstand. Good. Now, slow it down and make it so you have control. It's all the weight is already on your right leg even. Yeah, breathe behind it. Good.
Okay, so here's another one. Breathe behind it. You've probably heard Charlie Weingroff talk about breathe behind the shield. And some of my favorite guys this week. Gosh, what's his name? Mike on PRI. Mike. God, I can't remember his last name right now.
Cantrell.
Yep, was talking about how magical breathing when your body is in an optimal position. So basically, there is this idea: breathe behind the shield. Now breathe and own it. Right? If you don't, they'll say if you don't own a position, you can't breathe behind it. Right? And so once you get there, usually people will start to hold their breath in these really tight positions. And this is switching back from training to rehab, right? You know, if you're doing those big three, the breathing is pretty straightforward. You breathe, you brace, and then you move the weight. Here, he's asking her to control her breath while she's got this on fire, her glutes on fire, so that it further integrates kind of into the system. Let's go back here.
And now go down towards the ankle.
Okay, so now she's
making sure you're shoving your butt back. So less of a squat and more of a hinge. That's it. Now freeze. Get that knee over your ankle.
okay. So here's one I wanted to show you. Okay, so she goes and does that single leg hinge squat situation. She's a lunge with a deadlift hinge. However, her shin goes way back on this second one, on this right side. I don't know exactly why, but this does happen quite a bit. That means she's still kind of back on that other hip. She hasn't been able to come forward onto that front hip. So again, he's coaching her super intently, but he's just trying to make it symmetrical from side to side. There's really nothing other than that, I think, to think
And
about.
now when you go down, this is the action. So the butt's really stretching back. Now we have even more tension. Feel that? Hold it towards the ankle and now kickstand.
Okay, so now she's hinging, a single legging deadlift way forward. Her torso is way, way, way forward, like the beginning of a deadlift. And now she's hinging in a more, she's kickstanding in a more hinged position.
Those are the progressions. Crazy?
She's definitely a good sport. I'm not sure how many my patients would endure that one.
That was a long one. I mean, that was a 2-minute video. We stopped it a bunch of times, but that was 2 minutes of pretty much fire. She's like, I don't want to be your patient ever, a tutorial ever again. It's brutal. But I mean, look, that's 2 minutes and her body's demands and capacities were absolutely taxed,
Mm-hmm.
And so you can very quickly show where some of these deficiencies are. I think that's one of the big things that if you do have this amount of time, that's why I kind of had beef with patients that had gone to see PTs, and people would leave and they'd be like, I could probably do that on my own again. You know, if you're hands-on with somebody like that, I feel like you have a responsibility to work them a little bit, you know, instead of the mindless 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Man, Craig is all there. He is coaching her whole way through, and it's just 2 minutes. It's a long one, yes, but he's focused and dialed in for 2 minutes and just making her absolutely work.
Yeah, he is demonstrating that he's a bit of a linchpin too, because like you said, if they come in to see you and you are exercise-based clinician, but you're just giving them the bird dog and
what do you mean by linchpin?
Yeah, linchpin. Linchpin is like the pin that's on a wagon that would hold. It's like one bolt that would hold a wagon to like a horse, or something like that. Or in other words, if you don't have that linchpin, the whole thing falls apart. So, there's a book called Linchpin by Seth Godin. I highly recommend it. But yeah, in other words, I'm saying he is showing that he's necessary. So, like you said, if a patient goes away saying like I could do that on my own, you are becoming kind of dispensable in a way. So it could be, that's a little bit more semantics for your business and for patient retention. But I mean, not only is he necessary so that she does it correctly, but he's necessary because the demand is there for somebody to kind of coach this. I did have one thing before I forget, which is I like the addition of the weight, because I think it made it hard. Obviously, it made it harder for her because there's more like frontal and torsional plane demands by holding the weight, but it's puts you in a better position naturally. It's like a self-limiting move by adding that weight, because it just, then it automatically creates like her turning back towards the front leg more naturally, because that weight's going to be holding her there. You know what I mean? In a good position naturally, but it's going to make the exercise harder.
Absolutely. Yeah, I mean, and she has a really good job of kind of keeping her torso still and like not really rotating too well. She's clearly an athlete at some point.
Yeah, and right here, she either just lost focus of where she's supposed to be, or maybe the right hip is burning a lot worse than the left, so she just had to shift away, you know, until he made her go back to where she's supposed to be.
Right. Well, I mean, yeah, she's taxed, man. She is on fire there for sure. You're going to lose your position once you get taxed, and then having the body go back into it, man, there's a lot of learning basically that's happening in that position without him. He's saying a lot. I was going to say without him saying a lot. He is saying a lot, obviously, but her body is learning far more than the couple words that she's saying, if that makes any sense. Like, especially if you're talking about like, you know, we've talked about the sensation stuff with like the Theraguns and the cupping and the manual therapy. Like the one thing that I guarantee they're all doing, even if it's E-stem, there is a sensation created in an area passively, endogenously, exogenously, from the outside, from the inside, passively or actively. And so you had a good little post actually this week. You were talking about empowering the patients. Like, I know that he talks about this quite a bit. So like at the very end of that exercise, he was like, this is your progression. This is it. This is the thing you need to do. So he's taught this to her, and very likely that's her home exercise program. Right. And so he's created this little kind of feeling, the burning sensation that she just got. And so she's now got a new baseline for what that should feel like. You know what I mean? How many times, if you're a clinician, you ask a patient about their exercise, their clams, their glute bridges, and you're like, how are those exercises going? And they're like, good. I did them, is the general response. Versus, do you feel you have more capacity with those things I gave you last time? Right. So I imagine if this was me, this is what I would assume. She's going to go home with that exercise: monster walk to the side, kickstand out, bend, and do a little hinging in that kickstand place. Feel those glutes burning and engaging. Monster walk back the other way, do the same thing on the other leg, right? And she is to increase her capacity within those movements, that process of movements, basically.
Yeah. As I'm watching his videos in a row too. I'm also thinking about this idea where patients just need, I think so many people, and I'm not talking about athletes, but I'm talking about people that maybe used to be athletes or never were athletes, where we're just, unless there's some, I don't know, some spark or reason for you, you don't ever have to push yourself past any kind of threshold.
Right.
You know what I mean? Your new normal is, yeah, I mean, I walked for 5K. That was a long walk, but you could have no, kind of feeling like this lady does, this woman, as far as, wow, that's what lactic acid feels like, or that's what this burning feels like, or that's what my heart rate. I've never had my heart rate up above, 120 in,
Right.
15 years.
Yeah.
And I think, at first, if you all of a sudden smash your body and you're not used to it, you can almost feel a little sick, kind of feel like messed up, like woozy, kind of want to sit down, you don't feel good, maybe you're not even hungry for a couple hours. That is a sign that you are deconditioned to any kind of lactate threshold. Any kind of VO2 max is just terrible. But once you get past that, you can kind of get this euphoric, like you can feel how good this can be for you to push yourself past a threshold. That doesn't mean like zone 1, zone 2 stuff is, I mean, that's actually where you should spend most of your time, is, it seems these days. But what I'm just kind of saying, if you don't, if you never sprint, for example, then you never get that feeling of what it's like to push your body hard and fast. If you're only, a zone 1 runner, or when you lift, you do it more, old school Olympic lifting style, which is you do a single and then you sit down for 5 minutes and eat a donut, and you go do another single, and you go talk to people for a while and go do another single. That can become your new normal, or no exercise at all. So, I mean, this is what I've watched Dr. Liebenson stuff for years, and I have his book on my shelf, but as I'm just trying to think of something new here, this is just an idea that's kind of permeating through me right now. This idea of, especially in the rehab setting, we can be just too controlled and too slow and too not timid. I mean, you don't want to hurt a disc when they have a disc herniation, but pushing a person to grow, it's not always through just the reps, and it also can be through other systemic things in your body, like metabolic system, cardiovascular, lymphatic, sweating, all the heat, blood flow, all that stuff.
Right. No, I agree. And I think especially in the musculoskeletal world, this happens. And sometimes for new doctors, it can be frustrating. Hey, my back is killing me. Help me. Okay. How bad does it hurt right now? Well, right now it's about a 2, but when I wake up, it's really bad. Or at the end of the day, after I sit for a long time, I get up, I can't get back up. But right now, it's not that bad, actually. You know what I mean? And so you're like, okay, so I'm going to work on your back. I'm going to adjust your SI. I give you a hip stretch. And so if your pain is at a 2 and you come in to see me and you leave and your pain is at a 1, I cut your pain down by 50%. How much of a difference of feeling is that to the patient? You know what I mean? They're like, I'm not really sure what happened there. He definitely did. I heard a pop, or, I definitely feel beat up from the work I did. But so I'm saying in these situations when the chronic pain patient is super low, and they go through something like this sidestep series where they get this, what Bobby's talking about, this high metabolic return, they're feeling something. They're feeling that you made a change. This is definitely a time when you can kind of work some of this stuff in, right? You can really make an impact to the system over just kind of their one painful spot. I know Dr. Liebenson is a big on the Carol Lewitt, he who treats the side of pain is lost. And so that is, one of our favorite quotes here on the podcast. What were you going to say?
I say, yeah, I think it can be a little bit like when you dial in your nutrition after eating terribly for a long time. You kind of forgot what it can feel like to feel good. And I'm sure you've done this too, but I've had those periods where, like a couple of years ago when I was traveling the globe, I wasn't really doing any training. I was off work, just traveling. And there's been a few other periods from injuries and things like that where I haven't done a lot of legs. and then you come back and you start strength training legs quite hard. And it's not like just in the gym as I'm putting the weights on where, oh yeah, I'm stronger. It's just like walking around town where I'm like this, I feel better just in locomotion period, or in stance, or in anything. And it's like when you switch your diet and you make, whoa, okay, I didn't know what it feels like to feel this good, or not to crash every day at 1:00 and need 3 Red Bulls. So I feel like, again, part of this, like use that example of the 2 out of 10, they will notice something like that though. If their function and their capacity increases, that could be enough to just numb out something like a 1 or a 2 out of 10.
Absolutely. Yes. And so I think I can't speak for all the patients he's treating, but I feel like that's a good way. I mean, if someone's really, really hurting, I mean, I've seen some of his little case studies where he treats, and this is one of the critiques I think of him. He treats, and on his page, there's such a variety of different things that he's doing that it's kind of hard to keep up. But he's definitely kind of, I feel that like he's trying to find that window into it and kind of go from there. Okay, so let's find another way.
I have a question for you though.
Yeah.
Do you think that his plethora of different exercises is because he's being that specific, or do you think he's actually being quite general, and in the moment he's a bit like an abstract painter? He's just kind of saying, well, they need more hip stability and strength, and they need more frontal plane control, and they're a little bit deconditioned, so I'm going to put this little circuit together that'll kind of address all that. Because in that way, that's a bit general. It's, in that case, it didn't have to be this kickstand exercise. That's kind of arbitrary. You just needed that certain stressor. So do you think he's actually trying to be that specific with every person he sees, or it's a bit like, some Jackson Pollock stuff going on there?
I think two things. I do think that he has been around long enough where he can start to wing one of those exercises and find kind of the flaws and kind of fix them naturally. Some of those dysfunctions will pop out in an activity like the one we just saw. And so he can kind of, improvise. He can be Charlie Davis and jazz and kind of make it work. But I do know that maybe we probably should have gone through some of these posts. Maybe I'll pull one up where he calls it his audit. He'll do his specific audit, then he'll do his little movement audit, and then he'll go back and retest. And so we don't have one of those videos. I could pull up one of those videos. So yes and no. I think he's got a general idea. I can't speak for him exactly. I've seen him very specifically do an activity and then go back to a test, and the patient goes, oh, wow, that's a lot easier. There's one test. I mean, he does one of the tests that you were talking about, like a single leg squat. He has a guy sitting down on the bench with a single leg testing left versus right. And let's pull it up. Let's just pull it up.
Maybe we just need to get him on the podcast so he can answer that question.
I mean, I think that's perhaps the best thing to do about this.
Should I just read from Infinite Jest while you're finding it?
Right. Okay, let's see what we got here, Craig. Yes, we are making a lot of assumptions here, but here's this guy. Let me show you this fellow. Okay, so here's our man. He's got a mask on. No. Here we go. Okay. So he's going to go in single leg squat.
Any asymmetry, Nathan? True.
So he's doing a single leg squat and he's saying the left leg is weaker. He's just going up and down on a single leg squat, back and forth.
Left leg is weaker. True. Oh, no, that's your name. Nathan, true.
On this particular post, he gives some great patient profile information, actually.
So let's go over that real quick then. Okay, so fun to be back in LA Sports and Spine promoting sustainable athleticism. This is just the post. So original profile, severe low back pain, sciatica for months, sitting, AM, hurts in the morning, hurts with bending, surfing, running, and volleyball. Musculoskeletal part here, he's got a left lateral squat problem, rotary squat problem. I'm going to guess that's what that means. Currently, we're working, we've got substantial progress. That's good. The goal is for him to run volleyball. So this is part of his audit. Activities, surfing, training, new dad. Now he's got his painless dysfunction. This is what I was kind of talking about. Left subtalar eversion, energy storage release. Got it. So I'm going to guess his left subtalar is stuck in eversion, and it will not allow that energy storage release. This is his program, Copenhagen adductors. We can go over that in a second. Lateral squats, jump rope, one-legged squats, rotary, med ball, toss. How do you feel about this audit process here, Bobby?
I think it goes back to my question. I do think you're right. It's a bit of both in how he does this, but like you said, with the experience, with years, with like his kind of passion for these things, and thinking about it, writing books, big books with other clinicians,
right?
You get to this point where your color palette is quite large, right? And you can start throwing different paint at the canvas, and you can create something. And Pollock didn't make one painting; he made many paintings, and that and they all can can sell for a lot of money these days. So the point is it's not like you need to copy and paste what he wrote there as his program.
Right.
I think he's just saying, this is the dysfunction. This is what needs to get stronger. Here's a non-painful dysfunction that we can improve possibly. So that little, subtalar eversion issue might factor into the type of hip or low back activity he gives. Maybe that's why it's a lateral squat, not something else. Maybe that's why he adds a band. Maybe that's why he does a Copenhagen plank as opposed to the other things. But again, that goes back to your color palette. He has a large one, so you can color palette, that is. And so you can create when you.
He's got a lot of experience.
Yes.
So you can create a bigger program with that. Like a lot of the what you're basically saying is he can do a lot of different. That's what I was saying. Like with his exercise before, where you're like, is it specific or is it general? And I'm like, I think he's got the skill set we can go through, but hopefully we can kind of pick a couple little things. Like, I mean, honestly, if new doctors today got nothing out of the podcast, but they were able to look and find dysfunctional or non-painful dysfunctional patterns and learn how to recognize and fix those quickly, that would be a massive, massive thing if I was a doctor in my first year. If I could figure out how to do that, and Craig is very good at that, right? And sometimes it's a little tricky to convince your patients, hey, you really need to work on this left subtalar thing, because this guy came in for sciatica. He's got back pain. He's got a baby. He's holding the babies up early. He likes to run and surfboard. And Craig is like, well, your left subtalar gets stuck. There's a lot of energy stuck there. And the guy's like, I can just see a new doctor, treating a patient like that and not getting to a left subtalar dysfunction, right? But Craig has the ability to kind of show why that might be important, show the patient why it might be important, and put that into his rehab program.
Honestly, he could keep it to himself and sneak it into the rehab.
True.
And not take the patient's focus away from the fact that he just wants his low back pain to feel better.
Right. Let's go back to this guy and see what he did for this fellow who's got, the first thing we saw was he just has a bad left squat. The left side squat was weaker. So now, okay, so this is a good one. This is a good one to show. Okay. So he's doing med ball tosses, right? But he is talking about planting that left foot. And so this is hit back to his left subtalar eversion, energy storage release pattern. He's getting the guy to get a big metabolic load by throwing that ball, but he's also, and you could argue he's sneaking in, putting that left foot down. Is that fair?
Yeah, just to get some subtalar inversion.
Mm-hmm. I just love Craig. Oh yeah, he's into it, man. He is 100% hanging out and loves doing this stuff, though. I love it.
He does. Look at his office, stuff everywhere. He's just like a rogue wall ball target just to throw at him.
Totally. Oh, then you got an Olympic lifter over here working on an ankle mobilization. Let's go back to big man. Okay. Here we go.
I'm saying yes. Do a 5-minute test before you come in next week. Yeah. Okay. All right. Last thing.
So you gave him a 5-minute test run before he comes back. He's setting some standards. He's setting some goals, some baselines for the patient. He's dictating those. He's not letting the patient be like, how much does it hurt when you wake up? He's like, no, you're going to run for 5 minutes and you're going to tell me what it feels like in that situation. That's a pro move.
Thing we're going to do. You ready? Yeah. All right. So here's what you need to drop the weight.
He's back. Oh, no.
Pull back even stronger.
Here we go.
All right. I like it.
So now the guy's complaining about the cardio again, and the video keeps going back.
All right. So here's what you need to drop the weight. And what you're going to do is you're going to jump forward and land in your squat. Have you done this yet? Yeah. Okay. Yeah.
I think he's going to do single leg hops, right?
Yeah. So he's doing single leg hops. Stop it. Exit this. Let's make it end. Dang you, internet. So he's doing now he's doing single leg hops, energy storage and release. So I mean, he's staying consistent. The guy's broken a sweat. I mean, this is a common thing you're going to see in Liebenson's gym clinic gym. I can't think of a good word to mix them up, but his patient, the guy is breathing hard. He was talking about doing jump ropes. He's like, next time you come in, you're doing a 5-minute run. And the guy isn't, he's not Derrick Henry. He's not the Olympic lifter. He's a dad, and he may be somewhat athletic, but Craig is like, look, you can get in some work and you're going to be fine. And so it goes back to kind of what you were saying about feeling good after doing some good work.
Yeah. Yeah, for sure. I'm kind of wondering why an elite Olympic lifter was doing some kind of basic, almost old K-Star banded ankle mobilizations. Wondering why he needs that, to be honest.
That was just a fun aside. He actually, I mean, that guy's on his page very often, honestly. But he was also doing that on the vibrating machine, which is even more fun, right?
Whoa.
I know. Okay, so this is what we're going to get into the other one. The way that okay, so this is, again, the painless dysfunction. If you take nothing away from this podcast but this, find a painless dysfunction, make an input, make a big change in the person. So like, he always talks about the hips being a big one. And this is he loves this Koichi Sato squat, which is, I think he's a trainer, personal trainer or athletic trainer for the Minnesota Timberwolves. I know he used to do a lot of work at UCLA, but he's a big fan of this kind of lateral squat, and this is also a great little tip, working the frontal plane to get extension. Okay, so we got this lady, she's kind of in a staggered stance squat position, and she's got it's like a tricep ropes basically, but coming from her lateral side. It's probably about knee height, maybe about a foot away from her. And what she's going to do is squat basically back into the right hip, and that rope is also pulling her back into the right. So she's trying to do kind of a single leg hinge. She's hinging on both, but shifting her weight back into the right. And then she's going to come up into extension. And again, it looks like she's doing a lot of work here. Like you can kind of see as she pulls that weight, it is not a little bit of weight.
This kind of, to me, is like when they recommend, we have been recommended to do things in the scapular plane, because in the scapular plane, things work nicely together. Well,
right.
This position almost makes me think of the way that the actual glute looks, right? The way that it kind of diagonally runs towards the femur. So when she's contracting the leg, she's getting basically the external rotation fibers simultaneously working with extension.
Right.
That's why you're getting that rotary action combined with hip extension.
That makes a lot of sense.
Yeah. I like this. It's good. I don't think I maybe use this enough. Something like this.
This is a good one. I'll tell you about the version that I do. Okay, so now she's
Information as a test. So you've been doing these a while and noticing. And I broke the band. Noticing it was really weak.
too strong to break the band. She breaks the band. Okay, so let's go back to the beginning of this. So tell me, say it one more time about the turning of the fibers here, because that was, I love that. You got to say that again here. Here they go.
It's like the angle of force is going kind of diagonally through the glute from front to back, which kind of is, to me, it's almost like the scapular plane. It's like the gluteus maximus plane, you know, it's
right.
like, so as she extends her hip, she's probably going to increase the, you know, the amount of fiber contraction in different, because she's getting both ER and she's going into IR more as well. So she's getting more lengthening, like an eccentric load followed by a maybe a more maximal, or at least it's more dynamic in the sense that it's not just hip extension, but also external rotation and some frontal plane as well.
Extension. Yeah, she's getting all of them. Yeah.
Now double check your open chain.
Yeah, because she's going from adduction to abduction as well in there.
Right. Literally all of them, and kind of isolating, and she's just kind of pulling on that little band. And again, it looks like a lot of weight. She's breathing and she's moving. So that was clearly not the first time she's done those squats. I think this is kind of similar to it. This guy's page, Vernon Griffin, that I love. He has a bunch of kettlebell stuff, and Liebenson kind of credits this guy with it. So this is another version of that. And he starts off the thing and he's like, all right, let's explore the corners here. All right, so we got this nice young lady. She is holding a kettlebell. Her feet are out wide. She's got her mask on, so everything's safe. And okay, so she's lunging to her left side, keeping her right leg straight. So it's basically like a lateral lunge. So she's lunging to the left. She's got the kettlebell in her right hand. It looks like she's reaching her right hand for her left foot, basically, in a lateral lunge. And we're just alternating sides, left versus right, back and forth. Left hand, right foot, right hand, left foot.
Yeah, it's like a bit like a not too deep Cossack squat. But I like how the weight goes, you know, to the opposite hand each time, kind of turning the spine towards the leg that's being loaded, which is kind of maximizing, you know, especially you on this podcast, you've talked about kind of moving a pelvis over a femur. And that's kind of what she's doing, maximizing that with the weight. Is not just to add load, but that rotation of the pelvis and the spine to the leg that's loaded is like maximizing that centration in a bit. She's keeping her feet forward like 90 degrees. So as she shifts over that and rotates her body, she's getting maximal like IR. Yeah.
And now she's going to, so this is one of his retest. He'll go back to the Copenhagen adduction test, Copenhagen adductor lift, basically.
Hold that, tall, proud, hips forward. I like it. And how does that feel compared to prior? Now check the.
So he is going back to these things, but this is also the same thing. I love the way you kind of explained how switching through and kind of pushing through, because I know he does this in terms of like pushing out of that position. So like as she goes down and brings her right hand over down to her left foot, she's sinking back into that left hip. And he's talking about exploring the corner. So I've seen him do this in other poses where he just wants the person to kind of push further back and feel that femur push back into the back of the hip. And then actively, as we have found that Craig has loved to do, push out of that position, go the other way. So like initially, at least I would have them go a little bit slower and kind of find and really feel the back of that hip, right? Feeling that femur push in. And she's done really well. You can see on the left leg there, she's pushing on the inside of the foot. So she's shifting her weight over nicely. She goes back and she's pushing on the inside of the other foot, shifting her weight over nicely. I mean,
and you can see her medial foot and her big toes stay down the whole time. So she has the hip that can do this.
And then, He's also big into the rhythm, I've noticed. I mean, it's a pretty common thing to talk about, your body being out of rhythm, out of balance, if you will. And so kind of going back into that, but then he's just having this rep out, so like, yes, she is on her feet. There's a lot of things going on there, as opposed to an isolated situation, which may be more appropriate in other times, like a clam on the ground where you're just moving one joint. I can't think of a joint that's not really working there. You know what I mean? He's going after a lot of stuff. And then he is going back to that kind of test thing, obviously. But I do like that thing you were talking about, how the plane of the glute. I mean, that's another really big key, I think, into his success. What did you not like about that one, Bobby?
Nothing. I mean, I maybe wouldn't have liked it if she didn't have the structure for it.
Yeah,
I probably wouldn't like it, but she can tolerate that one, as far as I can tell.
Sure.
So, but again, okay. I mean, I can see, if you're a new clinician, you could see this and say, oh, I'm going to throw this in for a patient with low back pain. You still always have to have your basics. You still always have to know whether a patient can tolerate torsion or rotation or flexion, compression, right, shear, some of these things. Make sure that they have a hip before you go throw them into like bone on bone IR positions.
What do you mean? What do you mean have a hip? Hold on. What do you mean have a hip?
Well, I just discussed with her, she's able to rotate her pelvis over her femur,
right,
and get into pretty gnarly IR on each hip, yep, without, I don't see her foot move or pick up, which would kind of imply that, or her knee buckle out to the side, which would imply that she's smashing her, medial acetabulum into her neck of her femur and forcing everything to move out. Spine positions seems quite stable. In other words, she's doing it well. So I think this is fantastic. Like, I kind of want to go do this one.
It's a good one. Man, the PRI guys, maybe I'll pull it up. I forget his name, Mr. Compound Performance. We'll do these with a little bit quicker and with a heavier weight, where they'll basically keep the weight in the middle. Should have had this video up, and they'll go back and forth and they'll sync it up with their breathing. So every right arm forward, they'll exhale. Every left arm forward, inhale. And so you can start to sync those things up with the breathing. But hold on, I want to go back to what you're talking about, having a hip or not. Now, I feel like I know what you mean, but testing on the table, is that what you're also kind of getting back to? So like if you were doing some passive orthopedic tests and you could determine that, she wasn't ready for this? Because I'm trying to figure out if you mean active or passive, because a lot of times I'll put people on the table and they'll get crazy internal rotation. I'm like, oh, this leg is not in a good position. But then you have them come up actively and it's a totally different situation. How are you determining what is your way to determine, quote unquote, if they have a hip? How would you clear them for that? Well,
especially, I mean, passive.
Yeah.
Because if you can't do it passively, well, then actively there's probably no chance that they'll do it. And if they are doing it, then something is being sacrificed. I don't know if it's the lumbar ligament, or it's the capsule, or a knee, or something. But I mean, if you can't do it, so I was insinuating passive restrictions, sure, like bringing the hip into flexion, and before you even get to 90 degrees, their lumbar spine is flexing because the whole pelvis is basically counter-nutating.
Right.
I mean, I had a guy last week who, by putting his foot, like he's on his back, supine, 90 degrees knee. So I'm checking 90 degree hip flexion, 90 degree knee flexion, hip IR from that position, and lying on his back. Yeah. And from like -5 to -5. Mm-hmm. So he's in external rotation 5 degrees. Pulling him into neutral just shifted his whole pelvis and his back. Yeah. So he's -5 degrees of IR. He's not zero. He's behind it.
Right.
And I mean, even without major dysfunction in, femoral retroversion, anteversion, there's no major issue with that. Just like a capsular position, basically.
Right.
So I just mean, yeah, good luck doing this exercise on him. But I mean, I love this exercise. I got no problem with it. Especially this woman destroyed it. So
yeah, and I probably would look at something more like that Koichi Soto squat, with something like
Sure.
that, because he can put his feet wider. Let's go back to that one real quick. So you can go put his feet, a guy with, you know, those deficits basically. He can basically put his feet wider and then kind of pull his hip back into, you know, internal rotation, like you were kind of talking about with this girl.
Yeah, and you can prep the hip. You know, you can gain something and then load it, right?
Right.
So you could do some of those, you know, hip airplanes I was talking about.
Right.
You might gain 10 degrees of temporary range of motion, and then you
Right.
can do something like this, which is a bit less demand in hip flexion and IR. So
But
you can gain a little bit and then load it.
right. And I think this also kind of goes back to the thing that we perpetually talk about on this, which is say that, and we talked about this with the sports physio, our man Zach, a long time ago, about if you can get some increased internal rotation on the table. Let's say we've got your guy who's got -5 IR, and we loosen up his adductors, something like that, something generic, and he gains 5 degrees and he can get to 0, right? What's to say that he doesn't get off that table, take 5 steps, use his old musculoskeletal patterns, and then winds it back up? Which is why, if you have a situation where you can organically get them to gain those ranges and then recruit a bunch of other muscles around there to help you keep that internal rotation, that centered hip, basically. That's, I think, the other benefit of doing these kind of broader exercises like the monster walks and the split lunge and the kickstands, the side to side lunges, is that you may be able to stretch out an individual thing and get some range of motion. But if you don't use that, you don't groove that after the fact, then who's to say you won't keep it, right? I think that's one of the bigger things here. It may not be as, say, like specific as the FRC guys are with their ranges, but it's still a dang good way to kind of go after keeping those increased ranges of motion.
Yeah, exactly. And I do think that temporary, you know, the FRC guys sometimes are saying, you know, if you have to do a foam roller for an hour and stretch for an hour just to get into a deep squat, I wouldn't load that. That's not your real squat. But I also know from personal experience of doing like MMA and martial arts for quite a few years that I never really stretched, but I gained a lot of range of motion.
Right.
So sometimes that does come with certain movement demands. So you could increase your hamstring flexibility or your adductor flexibility by doing this last exercise we went over without doing any FR type of work. I'm a big fan of those guys for sure. I do their stuff. I'm just saying sometimes there's other ways that you can also get enough mobility to do things. You don't always have to break it down to, you know, just the IR of the hip and work that in a single plane and then, you know, and move up from there. So,
and I think to finish this off nice and easy, put a bow on it, I think Liebenson's way in are those pain-free dysfunctional movements. You know, those left to right hips where he can load up a hip and it doesn't hurt the back, or he can load up the opposite hip, get a bunch of load, get a bunch of blood flow, get a bunch of a metabolic response, a cardiovascular. There's some patients in there that were sweating in a pain-free kind of way, especially with those low-grade chronic ones, and finding those little windows in it. If you can get that into your practice, that's a massive, massive step. Have your audit process, have the test retest. These are some of the simple things from Craig. I don't even know if he goes over these in his classes or not. Maybe he'll come on and defend himself. Maybe not. But anyways, that was Craig Liebenson, single leg Craig day. Before we go, Bobby, any takeaways?
No. I don't think he has to defend himself. We were definitely supportive.
Absolutely.
But, and I've already given him whatever that cost to buy that book. So,
Oof.
So I think he has a new version of it too. So maybe we can get him on and he can talk about it.
Yeah, I mean, he's had a bunch. He's been a part of a lot of. I know he's got kind of part of the heritage of, you know, the way that chiropractic and physical therapy has changed since the 80s and 90s. So I know that he's got a lot to give. Go over to his page. I mean, he's got like 50,000 followers. But yeah, Craig Liebenson, single leg Craig day. Find us on YouTube, Instagram, share it with your friends. Tune in next week. Peace.